Welcome back to the Shared Practices podcast. I'm your host, Dr. Richard Lowe. You are going to be getting some solo intros and outros for a little while here. George and Natalia just had a baby, and everything went really well. They are now man-on-man defense. So George and Natalia already have a son. I think he's right around 20 months, which is about the same gap that Christine and I have between our 3-year-old daughter and our 5-year-old daughter. So everything's doing, they're doing great, but I've gotten a couple not panicked, but texts of, am I ever going to sleep again? It's like 5 a.m. and he hasn't gone to bed yet. So I do not miss those days of when you finally get one kid to sleep, the other one's up. For a little while here, I'm going to be doing these solo. I am actually recording this in my room in a barracks at Fort Knox. I'm getting trained as a medical recruiter. So I don't know how much we've talked about this on the show. I'm trying to think if in the intro and outro with Chris Merkley last week, if I mentioned this, but I am now a medical recruiter by day and a dentist by night. So the Army offered us a spot in Indianapolis as a medical recruiter. And that's where we're from. We're from Indy. And so my wife and I, we thought about it and looked at it. We jumped on this opportunity. We're probably going to get out of the Army from this position. So it sets us up to find a practice, to maybe partner in a practice. And I've got something exciting coming up that I can't quite talk about yet until a certain date passes and things have been finalized. But some really exciting news about how this is all developing and working out. So this interview is another interview I did at Voices of Dentistry. And I was standing there at breakfast with Dr. Drew Burns from the Fee for Service Dentist podcast. And there was this other dentist standing there, and we introduced ourselves. And sure enough, he's like an expert on case acceptance. I'm like, oh, we have to talk. So this is Dr. Chris Bowman. And I loved the specific language, the mindset, the framework that we set this up. He taught me how to say some things and phrase some things, and I tried to do it right back. And it's amazing how you can listen to something like this, and then when you go to practice it and actually say it in front of a patient, it's really easy to think you're saying it right. And there's little nuances to how you say things and the way you say things. And in the grand scheme of things, your attitude, your excitement, your care for the patient, those things will win out. But if we can hone and improve our language, that also is going to help. So you want both. You want the soft skills and also at the same time to have tools in your tool belt of how to talk about things and describe things to patients. So here is our interview with Dr. Chris Bowman. Before we get into the episode, we want to take a moment to thank Blue Sky Bio for sponsoring this season of Shared Practices. Our listeners know I can geek out about Blue Sky Bio. This is something that I love and I'm very passionate about. But Blue Sky Bio has realized that for every one geek that exists that loves playing with all these pieces of software and merging files and designing these things, there's probably 4 or 5 dentists that really don't want to mess with all of that. They don't want to be the lab where they're designing their own guides, 3D printing, processing, cleaning up, clipping, trimming, inserting guide tubes. They really don't want to add that workflow, buy a 3D printer, and truly taking the time to integrate this into their practice. Because of this, Blue Sky Bio has introduced something called Lab Pronto. This is truly the Uber of digital dentistry in terms of treatment planning, implants, surgical guides, ortho aligners. The way it works is once you're in the software with all the pieces that you need, there's a button that says Lab Pronto. You click on that, and now there's actually a list of labs with available time that you can choose to send your files to. They can help you treatment plan, they can help you print or design the surgical guide, whatever level you want to be involved with. If you want to do the design yourself and they print it, you can do it that way. If you want more help, if you want more of their involvement and less of your time, they can do that too. You are able to shop with a number of labs that are within Blue Sky Bio's network that understand what they're doing with this software and could really help you out by maximizing your time so that you can do more surgery, more ortho aligners, more patient care, and act less as a digital lab technician. To access these features, update to the latest version of Blue Sky Plan and just click the Lab Pronto button at the top of the software. We have with us today Dr. Chris Bowman. Chris, welcome to the show.
Hey, thank you for having me. Glad to be here.
So you are a practicing dentist in Charlotte, North Carolina.
That's right.
We just met through Drew Burns from the Fee for Service Dentist podcast.
Yes, that's exactly right.
I asked what the relationship was. You said you guys were dating. He's into older men. And I was like, oh, that's why he rebuffed me. I get it. Okay.
For those of you who don't recognize that, that is complete sarcasm.
Right. Sorry. So I just have to clarify. No, none of that's true. We love Drew. Not that way. So I am excited because as soon as we started talking and I told you that we're doing a season on case acceptance, you lit up. And this was something that I could tell immediately that you had a passion for, you had a skill set around, and that you do. And you told me that this is something you actively are doing right now, is helping people in this area.
That's correct.
So take us back a step. Tell us about your journey. Tell us about your journey from practicing and not focusing on this to realizing this held some importance and it was something that you could improve on.
Yeah, sure. Well, you know what I'm going to do first is go back to dental school.
Okay.
And just kind of retrace the way we've been taught. All dentists were taught a certain way to do things in dental school. And it really boils down to the simple act of first learning how to diagnose, learning how to recognize issues, problems, conditions, and diagnose them. So if you think back when you're in school and the instructor looks at you and says, or the professor, the doctor says, okay, what's the problem? And your first job is to identify the problem. And then immediately after that, okay, well, what's the solution?
Okay.
And you identify the potential solutions and the best solution. And then, okay, let's learn how to do that solution.
Right.
So the real simple formula of identify the problem, identify the solution, do the solution.
In dental school, it's all about the solution. It's all about
Correct.
Fillings and crowns, and you're getting graded on the solution.
Getting graded on how to do the stuff to fix the teeth or whatever.
Yeah.
So it leaves us behind because when we actually get out of school and get into practice and we're communicating with our own patients, something funny happens. It's not actually that funny, but they say no.
Right.
Or they say things that mean no or not now. And we're not always prepared for that moment when a patient declines treatment.
Yeah.
And, throughout my own career, my own practice, the frustrations and the struggles I had initially for the first few years of trying to gain acceptance for my best care, that's what drove me to finding a different way to present the same things to our patients much differently than we were taught in school. I got out of dental school in 1994, so I'm a little older. And, back then the formula was tell them what they need.
Yeah.
Just tell them what they need.
You need crowns, fillings, just what you need. Let's do it.
Right. And that's what I started doing with my patients. Hey, John, you need this, you need this, you need this. And I left out so much and I didn't even know it. I thought I was doing it the right way. And then when not as many patients were scheduling treatment,
sure,
it drove me crazy. And I wanted to find the answer. So, as dentists, we always look for cavities, right? We find cavities. Well, that was a big cavity in my practice. So I went on this search, this quest to find different ways to communicate with patients, different ways to discover how to get patients to say yes.
Okay.
So that's really been the focus of my career. I was a psychology major.
Oh, no way.
Yeah. So it's really funny as a pre-dental student, I felt like, well, I'm going to have to be a chemistry or biology major to be a dentist. Well, after getting into some of the advanced chemistry and biology courses, I thought to myself, this really isn't going to lend itself towards being a great dentist.
Right.
And then I found myself in a basic psychology course and I absolutely loved it because I was literally completing the sentences in my mind.
Yeah.
And I've always been interested and intrigued in human behavior. Like, why did someone just do that? Or why did that person not do that? And it turns out it's the exact same thing in my practice. Like, why did my patient not do that?
Yeah.
And why did those things happen that I may not want to have happen?
Sure.
So that background in psychology, that's where I really dug in as an undergrad. And that background in psychology led me towards a greater understanding of patient behavior, doctor and team behavior, marketing, all those types of things that in my opinion make the biggest difference in the practice.
That's really cool. And I loved like my psychology class. I took an AP Psych in high school, loved that, took some in college. My dad was, and this is cool that we share that my dad was a master's of organizational behavior. He got his MBA or MOB, and then he now trains crucial conversations from Vital Smarts. It's basically how to have difficult conversations, leadership, and things like that. Trains that professionally. And I'm a self-help junkie that always eats it up. And so it's like he'd have all these books laying around and just always trying to like figure that out and how to communicate better. It's a fun and difficult journey. And it's really easy to like deceive ourselves into thinking like, I'm pretty good at this. And then as I've found, even just here at Voices of Dentistry, I try and parrot back what someone has said and the way that they phrased something. And I can't even get the one sentence out. And I'm like, oh, how did you say that? That was so much. There's so much that we can do to improve. Even when we think we're decent at it, there's a whole nother level. So who were some of the influences for you in terms of coaching or training that you went to? How did you, once you realized I want to get better at this, what process did you take?
Well, about 6 months after opening my own practice,
Okay.
I engaged in some coaching programs
Okay.
because I knew that there were a lot of things that I didn't know. And, the first couple of coaching programs were centered mostly around systems and,
Sure.
and when you
Nuts
think
and
of
bolts.
when you think of a typical coaching program, those are the things that you think about. So the first two coaching programs were really about getting going and getting systems in place and making things happen. There was some communication elements to that.
Sure.
One of the big influences earlier in my career was Dr. Tom Orant.
Okay.
Many of you have probably heard of him, 1,000 Gems guy.
Okay.
So this is way back in 2002, and he kind of lit the spark. I'm not sure if that's the right way to say it.
Sure.
But he got it started for me as far as how to communicate with patients in a way to get them to understand that they have these problems that need to be corrected. And so it caused me to shift my focus from thinking just about treatment and quote unquote selling treatment. And I know a lot of people hate to hear the word sell, but let's face it, we're always selling.
Yeah.
And the way I look at it, you're either selling or you're being sold to. And even with a patient, if you really think about it, if you're communicating with a patient about their oral health conditions or about anything, even if it's elective dentistry, if you're gaining acceptance from the patient, then you are technically selling to the patient. Now, I don't recommend selling in the way a lot of us think about selling.
Sure.
If the patient is declining, avoiding, even distracting us away from our task of trying to get them to engage in the dental care that's going to help them the most, it has to be done ethically, by the way.
Yeah.
It all has to be in their best interest.
Yep.
So if you're presenting something in their best interest and they find a way to get out of it, they're actually selling to you.
And when you said this to me yesterday, that was like a light bulb moment for me. Like, you're right. We need to talk. This is something that I'd never heard anyone say. They're like selling you on why it's okay for you to stop trying, why it's okay for you to present less, why it's like, doc, I've got this, that I'm a special case, I have a lot of anxiety. And then like once you buy that reason, you're like, oh, okay, well, let's just do this. Let's just focus on this. And you kind of settle. And there's a balance between fitting treatment into their life versus kind of just like accepting the excuses that they give to themselves and that they give to you for why they don't need treatment.
Right.
And it's a fine line. That's a hard balance to find, where you want what's best for them. You know what's possible. They don't see that. They don't get that. And if you just take the comfortable route and buy what they're selling, I just have never heard it put that way, that the patients are selling us. And it's so true.
Yeah. And if you want to shift gears from selling to the word influence,
sure,
it's the same thing. So patients are influencing us to tell them that everything's okay.
Yeah.
I mean, really, that's what it boils down to. They want us to tell them that everything is okay and that they're going to be fine when they start asking questions like, well, how long can I wait before getting this done?
Yeah.
Oh, and we joked yesterday about the story that we all have in our practices where a hygienist or a dentist would say, hey, there's 6 teeth here I'm concerned about that have some areas of decay. We come up with all these different ways of saying the word cavity.
Right. Right.
and you say 6 teeth with areas of decay, and then about 10 minutes later, the patient looks you square in the eye and says, so what? Do I have like 2 cavities? And they're negotiating. Your patients are negotiating. They're trying to influence you that they have fewer problems than you just told them they have.
Yeah.
And they're trying to get you to say, yes, you do have fewer problems than I just told you that you have, to make them feel better. So it's actually a level of tension.
Yeah. No, you can feel that tension. And being aware of this idea and aware that they are, whether they're meaning to or not, whether it's, subconscious, they are influencing you. And it's almost like, and I don't want to turn this into something that's demeaning, but like when a parent knows that a child needs to do something, the child is like negotiating and influencing back why, like I already did this and this is good enough and all of that. And you're like, well, no, you need to do it. And that can be draining, and there's tension there. And that's why it's hard to be a parent. It's hard to be the adult.
Right.
And I don't want to demean the patient-doctor relationship, but it kind of turns into that a little bit when they're resisting the truth.
Yeah, not at all demeaning it. And I don't mean that either. So going back to what I did that was different.
Yeah.
And how did I get different results? Well, I took a step back and I thought to myself, gosh, if I keep talking to them about all the treatment that I'm recommending, and they still don't really fully understand that they have problems that need to be corrected, that's where the light bulb went off for me.
Okay.
And I started thinking, gosh, they're not going to buy treatment unless they know they have the problems. So where should I be spending the majority of my time? I should be spending the majority of my time discussing the problems.
Right.
Now, if you go back a step further, how do you recognize it's a problem? Well, it has to be going in a direction that's different than the direction the patients want to go with their oral health, for example, or maybe the cosmetics of their smile.
Right.
Whatever it is that we can do for them, stepping back and thinking, okay, where does this patient want to go? What are this patient's long range and short range oral health and cosmetic goals? That's step one. Finding out where that patient is and where they want to be in their own mind. Then when we do our exam, when we take a look, when we take the photographs, big believer in photographs. In my opinion, you can't talk to patients about their oral health without using photographs. They have to be able to see teeth the way we see them. And that's what we tell our patients. Hey, I'm going to take pictures of your teeth so that you can see them exactly how I see them. And then I can explain better about what's going on. They love this.
Yeah.
Some patients don't like seeing the photographs. It's because they're afraid to know about their problems.
They're negotiating right there. They don't want to embrace the truth.
Exactly.
They'd rather ignore it.
So in that situation, it's funny because I'll have a team member occasionally say, hey, Dr. B, Janice doesn't want to see her photos. And I'll say, that's okay. Just put them up on the screen because I need to see them.
Right.
So we still put them on the screen in front of the patient. And just because I say, you don't need to look at them.
Great way to just put it.
Yeah. Don't even worry about looking at the photos. I just need to see them. Right.
I need to see them big.
Yeah. Because I can't really do a great exam unless I have a great look at your photographs.
Yeah.
Going back to our sequence, find out what they want, find out what their goals are. And then we have to find the things in their mouth that aren't going in the same direction that they just told us they want to go in. And hey, this isn't heading in the right direction. Let me explain that. Let me show you what's going on here. And we're all trained as dentists to find out what's going wrong, what's not going well, and what doesn't look right. So, and it all begins with the team, by the way.
Yeah.
So my philosophy is if it doesn't look right, there's probably something wrong. And if you think about some of the things that dentists and team members say to patients, it's like, well, that looks okay. That looks fine.
Have you seen the commercials recently of Just Okay?
Yes.
Yeah. Where the doctor walks in or the nurse is there and the patient's all worried and he's like, well, how is he? And she's like, he's okay. And then he like walks up and he shouts down the hallway, guess who just got reinstated? And then he walks in and he's like, are you nervous? And he's like, yeah. And he's like, well, me too. And he's like, we'll figure it out. And then he leaves and the patient's like, what's about to happen?
Yeah, because he's about to have knee surgery or something.
Yeah.
And the guy's like, yeah, I'm pretty good. I'm okay.
I'm okay.
Yeah. Right. So,
but I like what you just said. And I love picking up little pieces of language like this. You said the phrase, if it doesn't seem, I can't even remember. If it doesn't look right,
there's probably something wrong.
Right. I love the way that you say that because that opens up like there are things that are, whether it's cracks or stains or other things that on teeth that could go either way.
Sure.
And we could choose to wait and watch.
Sure.
We could choose to treat and how the patient views those teeth and those issues influences what we do. And so when you say something like that, if it doesn't look right, there's probably something wrong. Then when the patient is looking at the photographs, then they're thinking, well, that doesn't look right. What is this? And they're asking us. So I love how that little phrase sets them up to be in the like, well, that doesn't look right. There's probably something wrong.
Correct.
That's a beautiful phrase. Sorry, I just had to stop and focus on that.
No, thanks. And if you really drill down deeper in that comment, if we think about just the word that, when we say to ourselves, let's watch that.
Right.
That looks fine. Well, what's that? That is the thing that attracted our attention. That's the thing that we noticed. That's something that the patient needs to know about. So I don't want to beat it to death, but it's important to think about the things that we just naturally say to patients and how that goes against, sometimes it goes against the patient's goals,
right,
of optimal oral health,
being
for
healthy,
example.
yeah.
Exactly. So when I started to focus in my practice on showing patients what their problems are, showing patients what their conditions are, and also getting them to understand that what they're looking at when they look at the pictures of their own teeth, sometimes we expect when they see photographs of their own teeth with all these old fillings and things going on, we expect them to be shocked. And sometimes they're not.
And they're just like, yeah.
They just go, yeah, those are my teeth. And what they're really saying is, I don't have any symptoms.
Right.
And I mean, we could go all day, but that's another thing is when they say, I'm not having any problems. And they only say that because we ask them, are you having any problems?
Right. You give them permission. It's like a little cop out for them.
Yeah.
You've like slow pitch.
And they say
you've
no.
said, hey, do you not want to talk about your teeth at all? And they say, no, I don't want to talk about my teeth at all. And we're like, okay, I guess I just asked you and you said no, so I have nothing to say now. By saying, do you have any problems? And they're like, nope. Okay, you just cut your own conversation off right there.
Yeah, or you create a conflict immediately when you ask a patient, and this is something that is done in so many practices, is one of the first things I try to get them to undo, is a hygienist, assistant, doctor, anyone, are you having any problems?
Anything hurt today?
And they go, no.
Right.
So then what do we go do? Then we go find a bunch of problems.
Right.
So we're now in direct conflict with what we just...
They've already like affirmed that they believe. I believe
Correct.
I don't have any problems. So what's the big deal?
So now someone has to be wrong. So I might say something like, have you noticed any changes to a hygiene patient? Have you noticed anything different since I saw you last time? And sometimes patients will even translate that and say, no, I'm not having any problems.
Right.
And I'll say, okay.
They'll say the conditioned response.
Right. So I'm like, no, okay, so you haven't noticed any changes. Well, let me see if there's any changes going on that you haven't noticed.
Haven't noticed.
And
so it's saying, even if the answer is no, that just means you didn't notice them. Doesn't mean they're not happening. So that also, have you noticed any changes, or have you noticed that there are any changes? What do you say it again?
Yeah. Have you noticed any changes since I saw you last? Yeah, that might be what I say to a hygiene patient.
Okay.
Or my team actually says this. So I haven't emphasized that enough, that the team actually drives 80 to 90% of the conversation in order for the doctor to be most effective.
Yeah.
And do you mind if I drill into that a little bit?
Well, like literally on Wednesday this week, I gave a presentation to, we held a webinar for our course that we're doing on case acceptance. And I painstakingly drew a graphic of dentist trying to put a rock up a hill by himself. And then I drew this ramp, and each section of the ramp was one of the team members.
Oh, nice.
And how if we put these systems in place and we train, then the team's doing the majority of the work and we just push it over the hill. So it sounds like we're on the same page with this.
Absolutely.
So I'd love to hear your perspective on how the team plays the role in this and what you've seen work with that.
Sure. And this is where I see practices really make the biggest leaps in their productivity and their profitability as far as gaining acceptance of treatment. So if you think about, again, psychologically, the concept of an interaction between a team member and a patient versus the doctor and the patient. And let's also think about the authority that each one has in the practice. So obviously the doctor is the highest authority in the practice.
Sure.
So the doctor should be the final say, so to speak.
It's interesting that you say that, because it's also the doctor has the highest authority, but they're also the only one that could have an ulterior motive according to what a patient is thinking.
Of course.
Because there's a direct financial benefit one way or another.
Of course.
That's interesting that the highest point of authority also has potentially a conflict of interest in one way, if they're not acting as a fiduciary, if they're not acting in the patient's best interest.
So if you think about it in a lot of practices, what happens, and again, there's a process to this that I teach. If a team member, let's just say it's a hygienist, a patient's in hygiene, and if the hygienist doesn't mention the things that she sees or he sees that don't go in the direction that the patient wants to go.
Yeah.
Now, any hygienist, any assistant, any team member that's been in dentistry for any period of time can usually recognize when things don't look right.
Right.
So they have the capability to recognize. I want to be clear, I'm not saying diagnose. I just want to get rid of that.
We skirt this line all the time. We're just like, we call it pre-diagnosis, whatever you want to call it.
Yeah, you can recognize things.
Yeah.
So anybody can recognize
talking about it.
Yeah. So, hey, I see something that you need to know about. So the team member has to bring it up first. If the team member doesn't bring it up first, let's say it's a hygienist, 45 minutes in hygiene before the doctor comes in, and nothing is said about the problems that are there, then all of a sudden the doctor comes in, and the doctor rolls up his sleeves or her sleeves and finds a whole bunch of problems. Well, the longer that patient is in the practice without any mention of the problems, the longer that they're going to feel that everything's okay.
Yeah.
And then all of a sudden, Dr. Moneygrubber comes in and finds all these problems. That's in direct conflict with everything that happened in the last 45 minutes.
Yeah.
And nothing was mentioned. So then
there was no fires to put out the whole time that you were casually talking about your teeth and your life and the hygienist and talking about everything else. If there was really something urgent going on in my mouth, wouldn't have you been freaking out about it, hygienist?
Right. Or at least noticing it and bringing it up.
Yeah.
Right. So the patient instinctively looks to the hygienist for confirmation.
Yeah.
And we've all had it happen in our practices. Do I really need all this?
Yeah.
And the hygienist goes, yeah, you do. Well, the patient just asked a hygienist for confirmation of what the doctor said.
Right.
So that, in my opinion, is going down the ladder of authority. And even though the hygienist is a professional and a dental expert, it doesn't make sense to ask the hygienist if what the doctor said is correct. But if you flip it and the team member brings it up first, hey, I see some things here I'm concerned about. Let me show you. Let me take these photographs and show you because you need to see this.
Yeah.
And I'm taking the photographs because Dr. Bowman needs to see it too. And see, this is what this looks like. This is what it means. And this is the direction that it's going. Dr. Bowman's going to confirm it. But this is what I'm concerned about.
Yeah.
So then when I come in the room, hey, Dr. B, looking at John's teeth here, and I saw these things I'm concerned about. I took a photograph. I knew you need to see it. And see, now the urgency is amplified.
Yeah.
The patient already knows. And let's suppose it's during a cleaning. During that prophy, the hygienist can continue to drip a little bit of information on the patient about what she's seeing, how it's important.
Absorb it over time.
And maybe even give some ideas on what can be done about it.
Sure.
So then when I come in, they've kind of teed it up for me.
Yeah.
And they share with me what they saw. Photographs already up on the screen. And now all I have to do, and you may have heard this before, some folks have called it the bobblehead. So I just come in, I'm the bobblehead. I'm like, yep, that's exactly right. I agree. Yep, I see it. That's what I would do.
So it's interesting that you're describing right now, rather than this interaction, when you walk in the room, the hygienist has told the patient, now the hygienist tells you, and the patient hears the hygienist repeat it again to you.
Yes.
That, I think that's essential, what you just said. Don't do the handoff in the hallway.
No.
Don't like say, okay, what do I need to do? What do I need to bring up when I'm in there?
Yeah.
Because it's almost like the patient, going back to the parenting analogy, because it just keeps working in my mind right now, plays off mom and dad.
Yep.
And if they went to mom and mom said no, but dad doesn't know that mom said no already, then they can work dad. So if they see that you both have all the same information and you're on the exact same page, then it's a lot more than their influence there of like, well, so, I don't really have, I've only got 2 cavities, right?
Yeah.
That's interesting. And I think that handoff in the room, I think is key.
It makes all the difference. And I notice whenever I have a fill-in hygienist on occasion, everyone gets a fill-in hygienist on occasion.
Yeah.
And I see this happen so frequently where maybe it's someone that hasn't been in my office yet. And I walk in to see a hygiene patient, the first patient, and the hygienist will kind of slide over a little Post-it note that has some letters and numbers on it, like
timidly
4DO.
sneaking.
And she slides it over to me and she kind of mouths it to me. I think he's got a cavity. And I'm like, tell me.
What? Say it again?
Yeah, tell me. And I want them to, and they don't say a thing because other doctors have instructed them.
You are not.
Don't say anything to the patient.
Yeah.
It's the worst advice you can give a team member. And it's the worst advice you could have in your own practice is to not let your team members talk to patients about what they see.
Totally.
It absolutely cuts you off at the knees. So when I'm confirming what my team members see, and now they're not diagnosing, they're recognizing.
Yeah.
And when I confirm that, and then I recommend the treatment, and they've usually foreshadowed that.
Yeah.
And they've even foreshadowed the approximate cost or the approximate investment. Patients are always going to be shocked by fees. So the earlier you shock them, the better.
Yeah.
Shock them early. Don't shock them at the end.
Right.
So step 1, find out what they want, what's important. Step 2, find the things that aren't going in that direction. And step 3, show those things to the patient right away. This is all done by the team. Step 4, when it's time the doctor comes in. I'm saying hygiene. It could be with a new patient with an assistant. Same thing. When I come in the room, my patients are already preheated. They already know about what's going on. And they already often know what a lot of the proposed solutions are going to be.
One of the things that I actually forgot about design ergonomics that I was reminded of recently was that there's a history between Dr. Scott Luna and Breakaway Seminars and Dr. David Ahern and design ergonomics. So if you go back to the threads on Dentaltown, originally where Dr. Luna laid out his first practice that he designed from scratch and did that startup, he used design ergonomics to design his office nearly a decade ago, and he continues to reference them in his seminars today. And you guys know I love overlapping, reinforcing opinions, and these two companies, Design Ergonomics and Breakaway Seminars, are united on so many things, and they are all about rethinking dental office design, maximizing the return on your investment, and the ability to get into your own practice sooner rather than later, and doing so via efficient design. They share central stocking, rear delivery, the layout of operatories, and the amount of space that you can get into a given square footage. They're on board. The other thing you guys know I love is contrasting opinions. So if two people agree on 95% of the things, I love to know what they disagree on and why, and that's okay. For example, when it comes to delivery, so where the handpieces are, Breakaway preaches rear delivery off a do-it-yourself head wall and some low-cost equipment solutions. And while this is extremely economical, this method can have an impact on your career longevity because of the ergonomics. In contrast, Design Ergonomics recommends over-the-head delivery that allows for more ergonomic efficiency, which provides the dual benefit of improved health and significantly higher productivity. While the Ergo solution is marginally more expensive at launch, they have seen offices both increase production and have enhanced profitability that easily allows them to recoup the costs down the road. To learn more about different delivery system layouts and how they can impact your practice, go to desergo.com, desergo.com/delivery-systems. And on that site, they've got all 4 delivery systems: over the patient, side delivery, rear delivery, and over the head. No matter what you end up going with, Design Ergonomics is going to help you implement it in the most efficient way possible. For maximum discounts and savings, be sure to mention that you're a Shared Practices podcast listener when you go to designergonomics.com. So I want to ask this with the finances. When the hygienist is giving a kind of a rough quote,
Sure.
how do you train them to, like, what do they say? How do you train them to give them a quote like that?
Yeah, well, I learned something from Bruce Baird a couple of years ago that I think is just awesome. And Bruce can easily pull this off. He will look at a patient and say, "Wow, looks like there's about $12,000 worth of damage in here."
Yeah.
And now that's not exactly what my team members say, but my team members will bring up the problems and show them photographs of the patient's teeth to them, quadrant by quadrant usually, sometimes arch by arch.
Yeah.
By the way, that's another.
So your team, is it the hygienist who's taking photos?
Any team member can take
Any
photos.
team member can take photos. That's something
Absolutely.
you've trained and drilled in. Are these like an intraoral photo or DSLR? Like, what do you take?
I'm glad you asked that question, because here's the important point about that. It's a DSLR.
Okay.
We also have the Shofu.
Okay, sure.
I can't remember the name of it. We just got it recently. It's amazing.
Okay.
The Shofu camera.
And those ones that one's like kind of like, just like our cell phones are getting really good to the point where stuff can look real fancy without it being some massive contraption with a lens and a ring flash and all that. But the Shofu kind of has a ring flash type thing built into it.
Yep.
And it's kind of like a point and shoot style camera that we were used to 10 years ago, but is giving you almost 95% of a DSLR quality type photo.
That's right. So the important point I want to make here with regard to photos is that if you take photographs of 1 or 2 teeth at a time, patients are going to think about their teeth in terms of 1 or 2 teeth at a time. If you take photographs of quadrants, they're going to be thinking about groups of teeth.
Okay.
If you take photos of an arch or a smile, they're going to be thinking about groups of teeth, a smile, or an arch. So sometimes, again, with fill-in hygienists or other hygienists that have been trained this way with an intraoral camera, which I'm not the biggest fan of intraoral cameras. because you walk in and a hygienist took 15 pictures
Right.
of 15 teeth. And sometimes I don't even know where the teeth are because they've got 15
You
photographs
can't
on the
tell which
screen.
one's which. And
Right. So the patient will point at
they're
the
all
2 or 3
zoomed
worst
in.
ones.
Yeah.
And they'll say, I want to fix that one, that one, and that one.
It's the menu.
Yeah. They just pointed to tooth number 3, tooth number 15, and tooth number 19.
Yeah.
And right beside those teeth are other teeth that maybe need more minor things. So I said, okay, forget that.
Yeah.
We're going to take photographs of quadrants, arches, and smiles.
Huh.
That's what we do.
Well, and I tell people that if you're not doing anything, sure, start with the intraoral wand. If you're ready to start doing comprehensive dentistry, if you're ready to start doing more involved procedures, that's when, if you want to do bread and butter single tooth dentistry, that's where the intraoral camera works just fine. It's way better than nothing.
Sure.
As soon as you're ready to start doing these bigger cases and having more comprehensive acceptance, that's when something like this DSLR quadrant, you said quadrants, arches, and smiles. So that's cool. And let me ask you real quick. I know you help people who do all sorts of different procedures. What is your practice and your kind of passion? What are the procedures that you're doing in your practice that's been your kind of main thing?
Yeah, well, I started my practice in 1996,
Okay.
and that was right in the middle of the cosmetic dentistry boom.
Sure.
You know, veneers.
Yeah.
And I had this vision that I was going to have a practice that was I was just doing smile makeovers all day long.
Sure.
And, you know, I do a higher number of smile makeovers than average.
Yeah.
But I also do other things in my practice. So cosmetic dentistry is a primary focus.
Okay.
We do a lot of smile makeovers. We do 6-month smiles. I'm an instructor for 6-month smiles. So
Awesome.
got a bit of bias there.
Yeah.
And of course, full disclosure. Also, I do Invisalign as well.
Okay.
So I do adult cosmetic orthodontics.
Yeah.
That's how we build that. I also do the pinhole gum rejuvenation procedure.
Oh, cool.
I was lucky enough to be at the very first ever course that Dr. Chow taught.
Wow.
It was funny because there was a dentist in New York that was at the same course. There were 20 dentists. 5 were international.
Okay.
Actually, I should say 6 or 7 were periodontists. The rest were dentists.
Yeah.
And this dentist from New York and I were competing, like, who's going to be the first dentist on the East Coast to do the procedure?
Yeah.
And he beat me. So I was the first in the Southeast to do the procedure.
Okay.
He was the first on the East Coast.
Cool.
I treat sleep apnea patients.
Okay.
And of course, we do restorative dentistry and,
Sure.
and you know, full mouth reconstructions and things like that. So my frontier is dental implants. I'm placing progressively more implants.
Sure.
I'm a little newer to the game on implants than some, but a couple things I hate. I hate endo and I hate removable.
Okay.
So
Fair enough.
I just don't do that stuff.
Yeah.
And so that's how my practice has been built. So we focus on aesthetic, natural looking results.
Yeah.
That's what we really promote.
Cool.
And we position ourselves in the market that way.
That's awesome. Well, and so, and I just want people to hear that so they understand that, like, that if that's the kind of practice people want, that's the kind of practice where you have to be taking photos of quadrants, arches, and smiles, and you have to have all of your team members well-versed, comfortable doing that for you. Because if you're the only one that can operate the camera, that's so much time in diagnostics that you're spending, and therefore there's a little bit of a resistance in you that, like, oh, okay, like I gotta take all these photos, and okay, you know, it's just harder. Whereas if they're doing it, they're proficient. So I wanted to ask you now, with the Shofu and the DSLR and your team members, for a consult versus a full mouth rehab, when do you use which one, and what percentage of the time are you now comfortable using the Shofu versus using a DSLR?
That's a good question. It's a little early for me to answer that because we literally just got the Shofu less than a month ago.
Okay, cool.
So we're incorporating it more and more.
Yeah.
But my entire team has been trained in the DSLR.
Okay.
So we have 2 of those in the practice, and now we have the Shofu. So we have 3 fully operational cameras that we use to take photographs of quadrants, arches, and smiles.
Okay.
We take the same photographs for every new patient, whether it's a consultation, new patient visit, even emergency visit. It's something that a lot of folks don't do, because almost every time when a patient comes in with an emergency, we find other stuff, right? Now, we don't need to spend time focusing on the other stuff, but as long as the patient can see those other things, now they're more aware. So it's all about raising awareness.
Inception.
Exactly. And you know, it's like, when you're here for this problem, you know, I just want to show you there's some other things here that will need our attention. We can address these later.
Yeah.
So this is one of the techniques that I use in my practice a lot. to avoid, because some of you are probably thinking right now, well, how do you avoid overwhelming the patient when you show them all this stuff?
Right.
Well, I call it the big gloss over. And the big gloss over doesn't sound very professional, but it's very effective. And it would go something like this. I'd say, hey, John, there's a lot of things here I'm concerned about. There's some things that we need to address. We don't need to do them all at once. So I just want to make you aware that there's some things going on, like we've shown you in these photographs. However, where I think we should start for you is right here.
Right.
And that may be perio. It may be that broken tooth. It may be something like that, just to get them started. So if you think about baseball, I just want them to get on base. I want a single or maybe a double. I'm not always trying to hit a home run. And in my practice, when I first started, if you go back to the beginning of our conversation, I tried to hit home runs with every patient. And anyone who knows about baseball knows that the players that hit the most home runs also have the most strikeouts.
Right.
So I struck out. I did hit some home runs, and I still hit home runs.
Yeah.
But if you think about yourself as a baseball player and you're getting ready to go up to bat, and the coach says, hey, go get me a home run, it's a lot of pressure.
Yeah.
But if you think instead, if the coach says, hey, go get on base.
Yeah.
Just get on base. It's a lot easier.
Right.
So it's easier for my team. It's easier for me, and it's easier on the patient. So that's how we approach it in our practice.
So give me the big gloss over again.
Yeah. The gloss over is, hey, I see some things I'm concerned about here.
Okay.
And I'll name those in general terms. For example, like cavities under your fillings. There's some cracks in some of your teeth. Some of your teeth have some new early cavities. We're also concerned about your gum disease. So there's several things we're concerned about. And we'll address all of them. I'm not going to ignore any of them. However, when you say however, it kind of takes all that stuff and pushes it aside.
Right.
However, where I feel would be best to start, where I would recommend that we start, is here with this thing.
Right.
This one or two things. And maybe it's a quadrant of dentistry. Maybe it's two quadrants of dentistry.
Right.
Whatever the doctor feels comfortable doing, whatever the doctor feels is most important to start with, let's start with that. So we're gaining acceptance on the first step, or maybe the first two steps of the process.
Can I try
Sure.
the big gloss over?
Yeah.
Let's see. Okay. So, as we're looking in your mouth here, we're seeing a few things that need addressed. And we're seeing maybe you've got some cracks here that we're concerned with, maybe some gum disease and some cavities that are starting. And we're not going to ignore any of those things. We want to make sure we address all the things that you need there. However, we want to start with this quadrant, this area of concern, these teeth, because we feel like we want to prevent these from progressing. They're the most urgent needs and a good starting point. Any critiques there?
Yeah, that sounds great. I will say one thing, if I may.
Yeah.
Yeah. So
Absolutely.
the only thing that I would alter a little bit would be to take out the word want.
Okay.
So, and this is another thing I hear a lot, and every once in a while it
What did I
sneaks
say? I'm
out.
trying to think.
We want to do this.
Okay.
This is what we want to do. Now, we want you to have the best oral health, but one thing that I kind of guard against is we don't want to present treatment to patients in terms of what the doctor wants to do. So in other words, hey, what does Dr. Bowman want to do next for John?
Right.
I don't want to do anything. What I want to do next for John is go out to lunch, right?
Yeah.
So instead, Dr. Bowman, what would you recommend next for John?
Yeah.
So if you want to step back a bit from that, based on what I'm seeing.
Yeah.
So back to the gloss over, see all these things I'm concerned about. We will address them all because we want you to have the best overall health. See, it's okay to say we want you to have the best overall health.
Okay.
Based on what I've seen, I'd recommend that we start here. So another way to think about it is based on the conditions that you have,
Right.
I would recommend that we start here.
I would recommend.
So it becomes a recommendation. I would say strongly recommend if you need to.
Yeah.
Whatever you need there.
Yeah.
But we're basing our recommendations on their conditions instead of on what we want to do next. It's just one of those innocent things that happens.
No, that's great. And this is why I'm so glad I get to hear you say something and then I butcher it. And then you say, good, but let's work on this one word.
Oh, you did quite well. A-, right?
Yeah. And it's so hard though, because I can hear it on a podcast and suddenly think oh, I could do that. I'm already saying that in my office. And then you try and say it and there's little nuance to it. And that's the value of someone who both has experience doing this, has thought about it, and has coached others, is that you can pick up on those little nuances and say, good, but let's try this again, but a little bit better.
Right.
So rather than I want to start here, I'd recommend, or I'd strongly recommend that based on what I'm seeing, this is what we do.
Yeah. And the only reason I could point that out is because I did it wrong for so many years.
Right.
That I discovered these things and I recognize, oh yeah, I'm not supposed to do that, or
Right.
I'm not supposed to say that. And of course, things slip out when I say them too. I try to be very careful. My team is awesome, and they are so smart. And that's another thing. Doctors have to really leverage the intelligence and the expertise that their team members have.
Yeah.
I tell team members, when I coach the dentist and all the team members, I tell team members, you guys are all dental experts. You're dental experts, and you need to be dental experts for your patients.
Yeah.
That's the way that you can treat them the best. It's the way you can help the practice the best. So take advantage of the knowledge and the skill that you have, and think of things that are in the best interest of the patient. It is in the best interest of the patient for them to understand their problems, the nature of the problems, how they develop, and what happens if they're not treated.
Yeah.
Like, what's going to happen if we don't do this?
Right.
So there are a lot of things that we haven't even covered today that are part of my process that are so important to include that. And if they're not included, then it can actually hurt your results.
One thing I did want to ask, and this is taking another step back because I tend to get fixated and distracted. You mentioned that you take the same set of photos every time, and everyone has their own kind of set. Usually, involves some sort of smile, retracted, occlusals. What's your specific 4 or 6, set of pictures that you take?
Yeah, we take between 12 and 16 photographs.
Wow.
But we do it quickly. It doesn't have to take that long.
Sure.
And I'll actually go through it in sequence, if that's okay.
Yeah.
Yeah. So we either do the full face photos at the very beginning or at the very end.
Okay.
And it just depends on that particular team member and how it works out with the patient. So it's one of the very first things we do.
Okay.
Actually, it is always the first clinical thing we do.
Okay.
So if it's an emergency patient, new patient, whatever, we are taking those photographs after the team member sits with the patient to learn a little bit more about them. So let's call that the preclinical interview.
Yeah.
We do that first. And then when they begin to do stuff, that brings up another good point. When you begin to do things, you got to let them know what you're doing and why.
Right.
Instead of just doing stuff.
Yeah.
So we take photos.
Hey, I'm not going to tell you what we're doing, but we're going to start. And the patient's like, what's going on? Why are we taking pictures?
Yeah. The only reason why patients ask questions and try to decline things like x-rays is because we never tell them why we're doing them in the first place.
Right.
So let's go back to the photos. So let's just say we start with a full face photo. So we take a full face smiling, full face repose. Those are the only ones we need full face.
Okay.
And then if you're using a DSLR, that's when you put the ring flash on or put the flash on and switch your settings on your camera. And then we're going to do quadrant photos.
Okay.
All right. So we do upper right, upper left, lower right, lower left. Actually, we go clockwise. So we do upper right, upper left, lower left, lower right. Exactly. Yep. Clockwise in the mouth, I call it. Yeah. And then we'll do upper arch, lower arch.
Okay.
And then we'll do the unretracted and retracted smile shots.
Okay.
So we go unretracted first, 3 views, front, left lateral, right lateral. And then when you put the retractors in, same 3 shots, front, left lateral, right lateral, biting, full occlusion, and teeth slightly parted.
Okay.
So about 2 millimeters or so apart. And those photographs can be very quick.
Okay.
So again, full face photographs. And then when we take our photographs of the intraoral shots, we lean the patient all the way back and we do the quadrants and arches. And some of my team members will actually do the smile photos first and then the quadrants and arches.
Sure.
Some of them do it the other way around.
Right.
It's really not that important, the exact
end with
order.
The mirrors and retract, or end with the mirrors or start with mirrors, whatever.
Exactly.
Yeah.
Yeah, whatever works out best.
So let me see if I can list them off now. So we do full face, smile and repose. Then we do quadrants clockwise going through the mouth. So that we're at 6 now. And then we do full arch. So 7, 8, upper, lower. And then we do retracted front, left, and right, and then a fully closed. So those are all slightly open, and then a fully closed, just the front.
Right.
So that's the last 4 to bring us to 12. Whew. Okay.
Yeah.
I feel like I'm about to get grilled by my pros mentor in residency right now.
And I probably didn't say it in a way that is the easiest to understand. So if you want to focus on full face and smile first, and then let's just say we're going to do the smile photos first. You're doing 3 unretracted. And then you're doing 6 retracted.
Right.
3 fully closed and 3 slightly open.
Okay.
So that's 3 sets of 3.
Okay.
Right. And then you go back and do the quadrant photos, which is 4, and then upper and lower arch.
Okay.
So that ends up being, I'm not even sure, 16 photographs.
Wait, so do you do the left and right, like retracted front photos, do you do all three of them open and all three of them slightly open and all three of them closed?
And we try to take the photographs at the same position at the same time. So for example, with retractors in, I'll tell, like, let's say I'm taking the photographs. I'll place the retractors in the patient's mouth and I'll say, okay, bite down, click, open slightly, click.
And then
I'll go
to the front,
left lateral,
and then to the
bite
right
down,
lateral.
click, open slightly, click, right lateral.
Does that put us at more than 12 then?
Yeah, I think so. Let's see. 3 sets of 3 is 9. Upper and lower is 11. Quadrants would be 15.
Okay.
And then full face smile would be 16.
Okay.
And then if you do repose, that's actually 17.
Okay.
Yeah.
I just wanted to make sure. I was like, wait a second. I love that you have a system and that you get everything and that you do it first.
Yes.
Because the tendency is to just get going and then the photos never happen.
Right.
And if your team just has the expectation, has the training, this is what we do, and we do it first, that's just part of the deal.
Right.
Then photos become less of a thing that we fight and thing that we're always like fighting or meaning to do and don't do and frustrated with. And it just is part of who we are and what we do.
Yeah. And it does a few things too for your practice. It sets your practice apart from all the others.
Yeah.
Unless they're doing this, and very few do.
Yeah.
And it also shows the patient that you're going to involve them in the process.
Yeah.
So before taking the photographs,
okay,
the first thing we'll do for you is we're going to take some photographs. It's going to seem like a lot of photographs, but we want you to see your teeth the way we see them. And that way you'll have a better understanding of what's going on inside your own mouth. So is that okay if we take your photographs? And they say yes. And now they know why we're doing it. Same thing works for x-rays. And this is another thing that I teach is what I call the quick look.
So wait, say it again.
Sure.
Because I was like thinking as you were talking. I apologize.
No, it's okay.
What is it that you say to make them okay with photos? Say it again.
Yeah. So as we start, the first thing we'll do for you is take a series of photographs so that you can see your teeth the way we see your teeth.
So that you can see your teeth the way that we see your teeth.
Yeah. And that's usually more than sufficient for the vast majority of patients.
Most people aren't going to push back when you say it. So that you can see your teeth the way that we see your teeth.
Yeah. And my whole point in doing this from a higher elevation view is I'm trying to make an impact on the patient, trying to make an impression on the patient that, hey, we're different.
Yeah.
This is different than what you're used to. And this is something that you have to introduce the patient to throughout the entire process.
Yeah.
We're going to be taking some x-rays now. And before we take any x-rays, my team members know to do something called the quick look.
Okay.
The quick look is real simple. Just going to take a quick look inside your mouth here and kind of see what's going on. And then based on what I just saw, I'm going to recommend that we take these x-rays. It's the same x-rays.
Right.
But we just gave that patient a reason why we're taking those x-rays for that patient.
Based on your teeth, we need these x-rays.
Right.
Which is based on all teeth, we need these x-rays.
Right.
But it just validates the fact that we need them.
Right. So you want the team member to avoid
Let me take a quick look.
Yeah.
And then you just look, okay, based on what I'm seeing, I'm going to recommend these x-rays.
Right. So what are they looking for? I again, probably don't have time to drill down into it too much, but they're looking for teeth that are at risk.
Yeah.
That's another term we use a lot. I see some teeth that are at risk. I'm going to take a couple close-up x-rays of those teeth so that Dr. Bowman can see them.
Right.
And that already begins to alert the patient to, hey, there may be some problems here.
Maybe there's some risk here. Yeah.
Right. Everything that we do is engineered to make the patient aware of the conditions going on in their mouths so that they become more involved, they become more knowledgeable. And the more they know about their problems, the more uncomfortable they are with their problems, which means the more motivated they are towards not only accepting treatment, but requesting treatment.
Right.
That's the key.
What are we going to do about this?
Exactly.
Yeah.
When patients begin to ask those questions, like, what do you see? Oh, what do you do for that?
Right. When
they begin to ask those questions, only then can you start transitioning to talking about treatment or solutions or things like that. If you jump too early to that, you're going to, I call it leaving them behind at the problem. You're going to leave them behind at the problem.
Yeah.
And you spend all this time talking about these beautiful crowns you do and this beautiful treatment that you do. And all the while you're doing that, they're just sitting there going, yeah, okay, well, I don't feel anything. I don't have a problem because that problem wasn't developed.
Right.
And that's the focus of my entire system is making sure that patients are aware of what's going on so that they're motivated to do something about it.
That's awesome. I love that you've thought about all of the little details and phrasing around getting to the patient at the point where it's almost like people are kind of like on autopilot. They're just going through the day. They're thinking about stuff. They're on their phones. They're worried about other things. And it can just be one of those like, okay, let's just get in, get out, move on with life. But each one of these little teeny steps that you do kind of like perks their attention of like, well, what's going on then? And well, is that right? It doesn't look right. Maybe something's wrong. So, and this is just one last, and we've really focused on the photography. So I want to ask one last question with the photography, and then we'll probably have to wrap it up. And maybe I can get you back and do another episode. Thank you. With those photographs, do you put them on a TV? Do you put them on a tablet? Do you put them in the patient software? What do you do with them after your team has taken them?
Yeah, well, we save the photographs automatically in a folder, in a computer folder with the patient's name on it.
Okay.
So we catalog all our photographs by patient name in folders.
Okay.
Real simple on Windows. Real simple process. The reason I do that is because then we can jump back and forth really easily. I can show patients photographs of other patients' teeth that are like theirs that we've treated. And that's a whole nother conversation.
Yeah.
And when you start to do that, then they start to understand the nature of a problem. That probably will require a little more time to discuss.
Yeah.
And then we put them on our 40-inch monitor that's in front of every patient chair.
Cool.
So, and we tell them, you're going to see your teeth the way we see your teeth. And when they hear that, they understand. And they also know that very few other dental practices are really doing it that way.
Yeah.
It just raises their awareness.
And when you've got these, so you've now taken these 15, 16, 17 photos, you can only really have one up at a time, right? I mean, you could try and put them all on there, but you wouldn't really necessarily want that.
No, one
at
a time.
You're clicking through these with the patient and kind of making some noises. Okay, with this, and then you start talking about what you're seeing there.
That's correct.
Okay.
Yeah. Now, and in fairness, we're not going through 17 photographs with every patient.
Okay.
So if it's a healthy patient with very few restorative needs, we're going to probably zoom in on the quadrant photographs.
Okay.
And maybe look for some early cavities or old fillings or things like that. A lot of what we spend our time on is the quadrant photographs.
Yeah.
Because then you can zoom in on sections of teeth.
Yeah.
For someone who have maybe more full mouth kind of case or full arch kind of case, we'll look at the arch photographs.
Right.
If it's someone who's interested in cosmetics, we're going to focus on the smile photographs. We do go through all of them. But just like a dentist looking at x-rays, you don't always zoom in on every single x-ray.
Right.
You're going to focus on the ones that require the majority of your attention. So same thing with patients. We're going to zoom in on the photographs that are most relevant for that patient.
Right.
And then dig into those details.
Okay. Awesome. We got to wrap it up time-wise, and it kills me because this is good. We're getting a lot of like really concrete details, which is what I really appreciate when people share things like this. So thank you. If people are interested in learning more about what you do, maybe they're interested in working with you because you coach people on how they can improve this. How do you do your coaching? Do you come in office? Do they come to you? Do you do it via Skype? Or what's your process with someone?
There's a 2-day course that I teach.
Okay,
and
cool.
It's called the Get More Yeses Advanced Dental Communication course.
Awesome.
So what we do real simply is we take the entire patient relationship process, beginning with the new patient phone call. And I train team members and doctors, the entire dental practice, on every step of that process. The new patient phone call. What do you do between the new patient phone call and the new patient visit to help increase the odds that they'll be there?
Yeah.
What do you do during the new patient visit? I discuss a concept called appointment choreography, where you slightly rearrange the steps of the hygiene or the new patient appointment so that you can implement this process more effectively and more powerfully.
Okay.
Everything for the what I call the problem presentation system, which we talked about a lot today.
Yeah.
Gaining their acceptance on treatment after you've discussed the problems to the point where patients want that. Financial arrangements, reappointing, referrals, testimonials, reviews. How do you capture those? How do you capture a video testimonial in 5 minutes or less that is incredibly impactful?
Yeah.
So those are all the things that are rolled up into this 2-day course.
Awesome.
So I'm actually in the process right now of finalizing the dates and the locations, but I can tell you that we're going to have courses scattered around the country. Hopefully one here in Phoenix, Scottsdale, where we are right now.
Cool.
Going to be looking at Dallas, maybe Chicago, or maybe Indianapolis, Florida, the Charlotte or Atlanta area, and then also one up in the New York, Boston area as well this year.
Sweet.
So we're looking at 5-6 locations.
Big old tour.
Yeah, doing a little tour. The best way people can reach me right now, we're also building a website. So we have a lot of things going on right now. The best way people can reach me who are interested in this process is to just email me. Real simple. It's chris@dentalinsiders.com.
Okay.
So chris@dentalinsiders.com. Just email me and let me know your questions. If you're interested in the course, you asked if I go to dental practices on a limited basis. If a doctor wants me to come into their practice and do the same 2-day coaching privately,
Sure.
I can do that as well. I don't have quite as much availability for that.
Right.
So
It's harder to do.
it's pretty limited because
Yeah.
I'm also teaching 6-month Smiles courses.
Right.
And somewhere in between all that, I got a dental practice. But
Right.
yeah,
You also practice dentistry.
yeah. And of course, my family is number one. But yeah, just email me.
Cool.
Anyone who's interested.
Cool. Awesome. Well, thank you so much, Dr. Chris Bowman, for coming on the show.
Thanks for having me.
Take care. Okay, I hope you guys liked that interview just as much as I did. I thought that was fantastic. So please reach out to Dr. Chris Bowman. Take one of his courses. I know we didn't have dates, but if you look him up, Google Dr. Chris Bowman or reach out to him directly, he'll have info there for you. I definitely want to get him back on the show if he's willing. Chris, if you're listening to this, we need to do another one of these. This was great. Another reminder, in February of 2019, so we're in February right now, we are doing a contest for tickets for Voices of Dentistry 2020. I won a free ticket by planking all over Voices of Dentistry 2019, and I won their social media post contest for day 2. So included with that was a ticket to Voices of Dentistry 2020 that I don't technically need because I'm going anyways. So the contest is a video testimonial challenge, and all we're asking you to do is to share a 30 to 90 second video clip of yourself. Super simple, doesn't have to be fancy. It can be just a phone. It can be like a selfie video. You can have someone else just hold the phone from a few feet back. Either way, I really don't care. And actually, we're going for realistic. We're not going for highly produced. Like, this isn't like, oh, these videos need to be perfect in some studios. It's like, no, like this is like a Snapchat video. It's not meant to be highly produced at all. So the video that we're asking you to create is how shared practices has impacted you in any way, shape, or form. Whether it's the podcast, whether it's our courses, whether it's a certain guest or a certain episode that really inspired you. If you've bought a practice because of our show, those we absolutely love hearing about your experiences, and is extremely motivating to us to continue to do this and to share what we've learned and our challenges that we're going through when we hear you taking action and using this information. Maybe you're a dental student and you're reaching out to practices because you're looking for one to buy. And so you're doing off-market searching and sending out mailers and reaching out to dentists, and it's actually working. And it's really exciting because now you've got potential opportunities. Maybe the podcast is frustrating. It's been frustrating for me and my friends at times when we feel kind of trapped by our associateship or residency or dental school, whatever it is. If you feel like, man, I just want to get there faster, and you hear all these stories of people who are doing it really well and buying practices straight out of school and being successful. If that's frustrating to you, like, we kind of love that. Like, we love that we're lighting a fire under you enough where you're kind of mad. Like, you're kind of like, no, I want this too. I can own a practice. So we'd love a testimonial like that too. So if we get enough videos, we're also going to give out admission to our courses, the Ownership Accelerator, as well as the Ultimate Case Acceptance course that we just launched and have had really favorable response already. So please go on our shared practices page. There's a description of the contest there pinned for the month of February, and post your videos. And remember from last week, the Wonderist video, done is better than perfect. My recommendation is just to film 3 of these real quick and then choose, so just do it once, do it again, do it a third time, or just do it once, one take, and it's great, perfect. But if you feel like maybe you're a little shy on video or you're not comfortable doing it 3 times, the first time you're like, okay, I can do this better. And then you try it again. We're going for authenticity and sincerity, just sharing your story and your experience. Even if you just binge listen to the whole show from the beginning, we'd love to hear those experiences as well. And then lastly, a huge thank you to you all. We are now over 250 5-star reviews on iTunes. That means so much to us in sharing our show with others and getting advertisers and being able to fund and continue to produce the show. It really means a lot to us when you guys go out there and review. So huge thank you. Almost caught up to Dental Hacks. They're in our sites. I think they're within 20 reviews of us. Lance Timmerman and Josh Austin on the working interferences. They're like the Howard Stern of podcasting. They've blown past everyone. We're never going to be able to catch up to them because they're just crude and hilarious if you're into that kind of thing. So we can't compete with that. But thank you guys so much for putting us as the number 3 ranked and rated podcast in dentistry. We really, really appreciate it. We'll talk with you next week on the Shared Practices podcast.